up to so much, Dr. Richard Adams and his colleagues, Dr. Abigail Kissel and Dr. Sari Barr. And they're going to be talking about their pediatric residency program and the program that they've developed, the CORE program, and how it is building collaboration beyond the hospital walls to improve child outcomes. So I am grateful that you have joined us. We will take a break for the summer and resume again in September. But I'm going to turn it over now to Dr. Kissel. Thanks so much.
Hi, everyone. Thank you so much for your attendance today. Dr. Barr and I actually went ahead and pre-recorded the presentation portion. We have been here, there, and everywhere in clinic. So we wanted to get that down, and I am going to go ahead and screen share that and play it, but we'll be available the whole time monitoring the Q&A and then hopefully having a really engaging discussion afterwards. So let me go ahead and pull that up.
Hi, everyone. Welcome, and thank you so much for your time. Dr. Barr and myself are really excited to present today. The topic today is collaboration beyond the hospital walls to support childhood outcomes. And we'll get into the thick of it, but essentially we're going to talk about teaching our pediatric residents here at UT Southwestern through an initiative called CORE, or the Community Organization Resident Practicum. So before that, we wanted to take a little bit of time to introduce ourselves. I am Abby Kissel. I was a pediatric resident here at UT Southwestern and then went on to be a chief resident here as well. During that time, I got to know a lot about the curriculum here as well as its strengths and weaknesses. And when I graduated from that, I spent some time working in both our complex care clinics here as well as our AYA or young adult clinic here, adolescent and young adult clinic. And that gave me sort of even more fuel to think about what are some really positive changes that we could make in our pediatric populations through really their development over time, over the lifespan from when they're very young into those teenage years and beyond. After that, I decided to go back and I actually became the first fellow here at our Developmental Behavioral Pediatrics Division. So yeah, I'm going to hand it over.
Hi, and thank you. I'm Sari Barr. I am a developmental behavioral pediatrician, and I am the medical director of the Developmental Behavioral Pediatrics Clinic and Down Syndrome Clinic here at Children's. I also am the program director for the residency rotation in developmental behavioral pediatrics. I came to UT Southwestern about 4 years ago in 2017 to help start the developmental behavioral pediatrics clinic here. So to start, we wanted to take some time to recognize why we're here presenting today. At UT Southwestern, we have been really proud to be part of this initiative and are thankful to be hosting this month's Clinical Scholar Series. We know that the steering committee has identified 13 topic areas that are important to clinical, educational, and research endeavors on behalf of young children across Texas. Today's discussion really fits in to the pedagogy and learning category. So a big thank you to Dr. Adams, our Division Director in Developmental and Behavioral Pediatrics, for inviting Dr. Kissel and myself to present today. So I think the best way to start talking about this project is to discuss the community and educational challenges that have inspired it. We first began surveying the Dallas landscape. We wanted to understand who are those community organizations that focus on child health and education, since those are also areas that we focus on as pediatricians. I myself am originally from Fort Worth. I lived here, I was born and raised in Fort Worth and left after college, or I actually left to go away to college and then moved out of Texas to the Northeast. And so growing up in Fort Worth, over time I've learned about many of the wonderful community organizations. However, when I moved away to New York, I had to relearn who was in the area, what organizations are there that I can partner with or that I could identify to help the patients that I was the patients I was seeing. And then when I moved back to Dallas, I almost had to relearn who is around and who is available to help our patients. How can we partner and who is in our community? And so that can be a really big challenge for those of us in the medical field who may be frequently moving to different cities throughout our education. So looking more specifically in DFW at nonprofit organizations, while this number may fluctuate, but there are currently around 37,000 nonprofit organizations registered. These organizations may their focuses will range from education to sports and recreation and healthcare, but we really wanted to look at organizations that are going to focus for children and look at those outcomes. So more specifically, there are many of them involved in the early childhood sphere. You can see here some of the ones listed that we have partnered with. Some of them are national organizations and some of them are more local organizations. Certainly, I had previously learned about the Dallas Children's Advocacy Center, and I work at Children's. But prior to this endeavor, I myself didn't know much about Commit or Early Matters Dallas, but now I am a larger part of those organizations myself. And so these are just many of the ones that we did partner with again for this collaboration. So in addition to looking at the community landscape, it's important to understand the physician's perspective. Not many organizations have physicians on their boards or as part of their leadership. And we wanted to know why. Well, some of the barriers to a physician being on these boards could be their time, could be money, since there's often money needed to participate on these boards, or just knowledge about the boards themselves. There are also organizations may find other professionals as more valuable, such as lawyers, people in real estate, or just other high-profile community members. There are, however, benefits to physicians and organizations when a physician is present on a board. Some of those could be just mutual interest in topics, or the fact that we're treating some of the after effects of those societal problems that may not be addressed systemically. I'm sure many of you have seen similar pictures, photographs, or representations of an upstream or downstream effect in problem solving. Specifically for us as physicians, we know that if there's an upstream problem, so for us, we're thinking about poverty, food insecurity, inequitable access to education, that as the family goes through one of these, has one of these problems, there's going to be a later downstream effect. And for us, we would look at poor health outcomes. It could put a child at risk of a learning disorder, another type of developmental disorder, or below grade reading levels. And so as a physician, certainly we are going to see these patients, we care about all of these issues, and we're going to treat them accordingly. However, we also know that it's really important to be involved in preventative care. And we want to, as much as we are going to treat our patients, we also would like to prevent the problem in the first place from occurring, or at least try to recognize the problem so that we can get our patients better access to better care earlier on, prior to those unfortunate developmental outcomes that could occur in the future. Now I want to take a minute to look at the medical education perspective in Texas. So specifically here, there are several pediatric residency programs across Texas. However, the UT Southwestern Children's Health Program is the only one in all of North Texas. we are major players when it comes to teaching the next generation. And I want to talk to you a little bit about what a pediatric residency program looks like. Many of you may not know what it is that pediatric residents actually do or have to do. And so although there may be some differences nationally, all residents have, there are some requirements that all residents all have to have. And so for most of residency, a majority of their learning is going to happen in the hospital. There will be there's a large part of their education that happens in outpatient clinics as well. There is a 1-month rotation that is focused in developmental and behavioral pediatrics. And so at our program, we do have all of the residents come through developmental behavioral pediatrics, either for at least 1 month. It could be 4 to 6 weeks, depending on the program. However, there's a lot to learn over that short time period. And unfortunately, thinking about advocacy and learning about partnerships in the community is not one of the largest goals of those rotations. There is an advocacy rotation as well, where the residents might go out into the community to learn about other community organizations. However, that one might only be about 2 to 4 weeks, and each resident might have a different type of experience. So I think that in their process over 3 years, the learning process for residents is focused heavily on the medical needs, which of course is extremely important as doctors going out and treating these children, but there's not as much focus in community organizations and advocacy. Additionally, our national organization, the American Academy of Pediatrics, has stated, of course, that these topics are important and do need to become a regular part of pediatric education and practice. I think there's a big gap in knowing that there's a problem, but actually implementing that into the curriculum, which is what you'll hear about soon and how we've tried to address that problem. Certainly as developmental behavioral pediatricians, we are all very, very interested in these roles and all of the factors that could contribute to a child's developmental success. So how did we get started? We first surveyed our own pediatric residents to establish the current climate in the program at Children's Health. As you can see here on the slide and looking at these graphs, our residents know that this is important, and they certainly want to know how to serve in these roles and advocate for children's welfare. But they report that they're interested and they find it very important to do so. Sorry. Okay, let me just start that over and reiterate what we're seeing here on these graphs. Certainly, the residents noted that it is important. This is an important role for all pediatricians, and they definitely show interest in using medical knowledge to advocate for children's welfare. Nobody has said that they felt that this was not at all important. However, residents also noted that they do have suboptimal knowledge on these organizations. You can see that they're most entered in the suboptimal or not at all optimal category, and no one felt that they were very knowledgeable of these community organizations here. Also, looking at these surveys, the residents noted that they did not feel very prepared to do this at the city, state, or national level. You can see here in all of this bar graph that all residents answered in the suboptimal or not at all. Nobody answered that they felt very prepared. I'm sure not many of us feel very prepared when asked some of these questions, but certainly we would hope that our residents who will soon be out in the community as pediatricians will feel more prepared when they are finished with their training. So now I'm going to ask Dr. Kissel to talk about a solution that we came up with here at UT to address this gap in the community.
Thank you, Dr. Barr. So again, just like you're used to, let me get in there, just like you're used to seeing the upstream, downstream, I know everybody has seen a lot of pictures or heard a lot of talk about silos. And sort of my soapbox silo is this clinic to community silo. And that's because I've really found that in medicine, we desperately want to use that health and education knowledge that we have to really help all of these kids in the community. And when I talk with and meet with community partners, they just continue to emphasize that they want to use their community and education knowledge to improve kids' health. So clearly, we both have these very similar goals, but somehow continue to operate within these distinct silos. And it's not unique to Dallas, but since we're here in Dallas, we thought, here right now, you know, what can we do about this? That became the question. And CORE, or the Community Organization Resident Practicum, it's just one of the approaches that we decided to take to address that. Specifically, as a fellow, speaking a little bit more about pediatric training, one of the things you do is that you have extra time during your training to come up with a project. Oftentimes that can be research that's clinically based or basic bench research that more has to do with aspects outside of clinical practice, but still the science behind the medicine. In developmental behavioral pediatrics, I did some projects like that, but I was really lucky that my mentors and supporters asked me to think a little bit outside of the box too, and to think about a project that would speak to the roots of DBP, or developmental behavioral pediatrics. And for me, that really meant what's not just happening with a child or a family when they're at my office in a clinic visit, what is happening in the rest of their environment, whether that's at home or school or out there in the community. How do we touch all of those pieces? How do we bring them together? And from that, CORE was born. So again, I mentioned it stands for Community Organization Resident Practicum, and it was first designed as just an elective, or what we called a selective, for the UT Southwestern Pediatric Residency Program. And I say selective because we did ask for highly engaged residents. We asked them to write a short application, a one-page sort of blurb on why this would be something they'd be interested in adding to their training. And we offered it for the first time in 2019. We wanted to keep it very small and personal, and we started with a group of 6 interested residents. I'm sure at this point in the presentation, after hearing all of the problems that we saw around us and what we wanted to solve, you're asking yourself, but what exactly is CORE? And so what it is this 2-week initial elective taught by leaders of community organizations, and I'll touch on that in a second. And then it's followed by a mentorship pairing. So each resident that's in that elective gets paired with essentially one of these leaders for the rest of their residency. And for them, that usually means anywhere from 1.5 to 2 more years that they have this touch point back with that mentor. And as I mentioned, you'll notice I said that this is taught by community leaders. So we knew enough to think that this wasn't something that could be taught again by other physicians. We didn't want this to be within the hospital, even within clinic, whether or not that was inpatient or outpatient. We figured that as physicians ourselves who knew that we didn't have this curriculum going through our training, that we didn't have the experience to be teaching this. So we really relied on community partners like Laura Kender, who's the chief of ECI and NHMR in Tarrant County, and Regan Horchow, who was a board member of Early Matters Dallas and a huge, huge community liaison in helping me design this program. It sounds corny, but we really focused on this idea, this concept that we needed the experts in these areas today to teach the pediatricians of tomorrow how to be leaders in these fields. So in terms of a breakdown, a day-to-day, what did we do in core and what did it look like? Each day, I tried to really focus on preparing for a certain event or talk, the talk itself, and then breaking down the concepts afterwards. So we did what we called pre-brief events and debriefs. And in a pre-brief, I really asked those residents to sit and even write down or jot down some thoughts or questions or concerns about the upcoming topic. They had the schedule for the 2 weeks and they could see who was speaking or teaching that day. And so I asked them, what do you already know about this or feel like you know about it? Where do you feel like your own knowledge gaps are? What do you think you're missing and hope to learn from this person? And then oftentimes we would also discuss sort of what are your fears on this topic. We really tried to touch on a huge array of things. Some of the topics were more sensitive than others. We talked about unconscious bias. We talked about race and medicine and race and access to community resources. And so it was a place where I really pushed them to think about these topics in ways that I think we often are not asked to think through medical training. Then we had the events themselves, and we will talk about those on the next page. And after each, we followed this with a debrief. And that was to sort of download this information we had just learned. So oftentimes I asked them to do bullet journaling, and whether that was in the moment or overnight as homework and bringing it back the next day. I really pushed them to say, what are actionable things you could do with the information you just learned? What are ways that you could connect that or integrate that into your practice now? And then, even though we did this individually, we then kind of came back as a group and talked about it, shared ideas, passed all those concepts around. I think at the end of each year of core, when I talk with the residents, they all mention that this process really sort of helps them both get in the mindset, get ready and prepare for these talks and topics, which was a really big deal for us because we knew these very important people were coming and donating their time to have these small group discussions with our residents, and we really wanted them to be prepared and ready to engage on the topic. They also mentioned that it really helped afterwards to sort of solidify the concepts that they had discussed and really drive home not only what have I learned, but how can I use that information that I've learned. So the events, or I guess we'll call them events, but they were a lot of different things, included many speakers that we were, again, so fortunate to partner with. And I only listed a few here. They would take up this whole slide, but people like the superintendent of Dallas ISD, the CEO of Dallas After School, chairmen, presidents, policy advisors, executive directors, just this fabulous group of people who are out and about in Dallas doing such important work that our pediatric residents hadn't had prior exposure to necessarily. At the same time, I wanted them to go out into that community and engage. And while this was much more difficult this past year with COVID, in general, and especially our first year in 2019, we went out and we did these experiences. The picture here is from Bonton Farm, which, if you don't know, is a sort of agricultural urban farm intervention in South Dallas, in the middle of one of the worst food deserts in Dallas, to sort of address that issue there, a really unique idea. They've actually also, in the midst of this urban farm, established a restaurant where people can go to get work experience, and where also they use all of the produce from the urban farm to sell and make a profit to go back into Bonton Farm. So a really cool experience for the residents. We also did a cost of poverty exercise. This is actually designed by Think Tank, but it's run through a local Dallas church. And it's where you go, and we actually, in this, partnered with the rest of the residency program. So not even just those 6 residents on our elective, but the rest of the PEDS residency program said, actually, that sounds really interesting. We want everyone to go. And so we ended up having something like, I want to say 45 or 50 of these residents there doing this simulation experience, which is designed to sort of expose you to a month or two in the life of a Dallas family living in poverty. What sort of choices do they have to make, like accessing healthcare versus feeding their children, transportation issues, again, experiencing inequity or racism when it comes to accessing social supports and services. And so that was a really impactful exercise that we did with COPE and then also got to debrief with them about afterwards. Our advocacy training was run through Stephanie Rubin and Sandra Lehman in Texans Care for Children, who are a big legislative advocacy group down in Austin, and were kind enough to come up and spend 2 days training our residents about what it means to advocate for children on different levels. Some of the ones we asked about in those surveys, so at a local or city level, at a state level, at a national level, and even a little bit at an international level. And we were so fortunate to also have someone from Fleischman Hillard Consulting come in and talk about really the nuts and bolts of that. So if you're going to be deposed or go to kind of Congress and give a presentation on, as a medical expert on a topic to help advocate, what does that look like? How do you deliver that interview? How do you make it impactful? How do you get your points across? It was a very, very interesting talk, and our residents responded really well to all of that advocacy training. So obviously, after running this elective for 2 years through 2 cycles, we wanted to start saying, what are some of our short and long-term takeaways? And this is partially us meaning us at UT Southwestern who designed the elective, sitting down and brainstorming together. And it was also partially really asking those residents and our community partners, you know, what can we do differently? What can we take away from this experience? One of the things that I really pushed the residents on, the ones who went through the program, was, you know, what actionable things can you incorporate into your current practice? So again, to go back to their training, all pediatric residents, when they're participating in the residency training, do something that we call continuity clinic, but it's basically their outpatient general pediatric clinic training, where they go back and hopefully carry over time their own patient panel. It's also a great place for them to implement ideas or changes that they're able to kind of educate their patients about and their patient families about. So really push them, you know, what can you do now? Take this information we've talked about. What are you going to change in your practice? And some of the things that they came up with were great. The majority of them had never heard of Dallas County Promise, and we're really excited to begin to discuss this sort of educational offering with their patients and families who didn't know about it either in many cases. All of them got to learn a little bit more about target grade level reading by 3rd grade, or you're 4 times more likely to drop out of high school, as well as the 30 million word gap. And in DBP, of course, we focus a lot on language as one of those really early developmental markers. So getting all of that extra education about those things really had them feeling like they could do more to advocate for their families through programs like Reach Out and Read and similar book distribution programs. We talk a lot about public pre-K for children with disabilities, or just public pre-K for low SES families, both in our DBP rotation, and it was something that we discussed and talked with those community players from the programs about in core. And so they felt much more comfortable having discussions about both of those things with their parents or families in their clinics. And then I think one of the biggest other differences was just, instead of giving a sort of nameless, faceless resource to a family, or a handout or a website or a link to go to, many of the residents felt really empowered by the fact that if they were sending them to a certain Dallas community resource, that they knew the president of that resource. They had sat in a room with them and discussed in a small group, you know, all of the issues their patients have, either using that service or getting into that service, or how to access that service best. And so it was often by name that they were referencing some of the leaders of these organizations to their patients and families. So we also wanted to ask them and ourselves, sort of, if we stretch, if we try to predict the future, or look to it at least and say, what do we think could come of this type of program, kind of far out? How do we start to move upstream? How do we integrate these concepts and create systemic solutions that are going to address these problems? And some of the thoughts were, you know, can we make this dream come true? Can we have pediatric residents or pediatric physicians begin to serve as medical advisors to, or even members of these community organization boards? Can we practice public health research that includes advisors from community organizations, meaning not just in this academic silo, not just within medicine, but can we pull in those experts from the community and design research projects that are really going to wrap around in terms of patient and child care? And obviously that advocacy piece. So can we teach future pediatricians to advocate as experts, which they are on these pediatric health topics, but really to show them how to help shape and create national campaigns for legislative change. So we showed you, or Dr. Barr specifically showed you some graphs that talked about preliminary survey data that all of our residents took before exposure to this elective. You saw how they wanted to be involved, they felt this was an important role, but they didn't exactly feel confident in doing so on any level, nor did they really know how to go about doing so. And so one of the other really important things to talk about is after core, will there be a difference? Right now, this month, graduating residents will get a similar survey that asks those questions. And one of the things we'll look to is for the residents who took this elective versus those that did not, how do they feel on those questions now? Does that change? Do they really feel ready, or at least more ready to advocate? Do they feel like they have a better idea of how to implement some sort of leadership role for themselves? And then we also will be sending a sort of practical application leg of that survey. And by that, I mean that about 1, 3, 5 years at those intervals after graduation, our pediatric residents will receive a survey that asks if they went on to fulfill anything sort of in those roles. Were you a leader? Were you an advisor to? Were you on the board of some sort of community organization? How are you integrating? And that'll really allow us to both look at, is this elective having an effect, the effect we want? And is there a way to sort of expand or change in order to enhance that effect? So we've done this for 2 years through 2 iterations. And a really big important part of that is sort of the process improvement of the elective itself. And to do that, we really have to gain some perspective and some feedback. And that comes from a lot of different people. But we felt like for community feedback, one of the best ways to look at that or to judge that feedback was to see from year 1 to year 2 who came back, who wanted to join us again in this initiative. And the answer was really everyone. Everyone that we talked to said, yes, please sign me up again. This was a rewarding experience. And they often brought other ideas or other organizations that they thought would be good partners in this project as well. So that was very flattering for us. And it was probably kudos to the first group of residents who were so engaged and interactive during the elective. The other group that obviously we want to ask are the residents. But there were sort of 2 different subgroups of residents that were important to think about. And one interesting one were pre-residents. And by that I mean before you apply to pediatric residency, you do medical school. And a lot of those medical school graduates were in the process of looking at UT Southwestern Pediatrics as a possible placement for residency. And while they looked at us in our residency recruitment package, we have course information on the core elective. And all of a sudden, during application time period, I personally, because my email is on that information, started receiving emails from these residency applicants that were so interested in this topic, which felt great for us, but also sort of reconfirmed that while residents are really interested in this, they do feel like they need more training specifically in this area. So clearly, the last group to look to would be the residents who actually took took the core elective. And I just put a few of the quotes from them on here. The first being anonymous because we do collect some anonymous feedback on all of our elective rotations at UT Southwestern, and the other two were volunteered. I won't read through them. Hopefully I'm talking slow enough that you'll have time to read through them on the slides, but I will say that recurring themes in these and others that I received from the residents through feedback were that, yes, this was a great experience, but more importantly, I really sort of got a better understanding of my place, and how I could integrate with the community, as well as hopefully utilizing some of these specific skills that we learned in my future career as a pediatrician. So that's a lot, and it's been a really fun 2 years, but the question then remains sort of, where do you go from here? We saw this problem that we saw as being these really distinct silos in medicine versus the community. We sought to come up with a solution, and obviously since we were trained through pediatrics, the solution that made the most sense to me was to work through pediatric training to address some of that, but where does it go in the future? And we decided we wanted to build off of these core principles, and that pun is intended. We wanted to continue this elective for any residents who did come through UT Southwestern Peds residency and were interested, because it's a very fun elective to be a part of. We wanted to expand the Dallas and UT Southwestern audience for these community organization leaders. I can tell you, having run this for 2 years, that every time, and even the second year I hear the same person from the community organization speak, every time I learn something new. And I keep thinking, I feel so privileged to be a part of learning this about this organization or about this person or about the work they do, the research they do, and I just want everyone to have access to that same information in that format, told by someone who is so passionate about the organization that they help run. So we'd love to expand that audience. And then thirdly, we would love to just spread the concept. So any other pediatric residency programs who are interested in creating a course like CORE, we would love to talk to them about how to sort of implement the same idea in their own communities or their own cities. So I think that's it for today. We really need to say a special thank you. I know I mentioned her before, but Reagan Horchow was a huge part of this process, designing, implementing, connecting us with these community partners, and so special thanks to her. To all the CORE community members. I could not fit them again on the slide, but they've just been so obviously the most instrumental part of this curriculum. And then to my mentors and partners here, obviously Dr. Barr is one of those, but Drs. Adams, Menezes, and Borges Edgar as well. And then a big thanks to the UT Southwestern Peds residency program, who obviously were the guinea pigs for this project, but hopefully willing to do that. And so far, our feedback has shown that they've enjoyed it as well. Dr. Barr and myself are happy to and hopeful to take any questions and have any dialogue after this. So thank you again for allowing us to.
Okay, we have a couple coming in. The first one I see here is from Kim McPherson, and it says, what type of learning or impact did you see related to promoting public pre-K? So that's a great question. I think it would be, I'll give you the mini answer, the most straightforward answer, and then a longer version of this answer. So I think the most straightforward is that we saw an impact on the residents in the elective, because by having speakers come and talk to us specifically about public pre-K, they felt, like I mentioned, more equipped to have that conversation with other families. I think the longer answer, and perhaps what you're getting at, is what outward ripple did we see that? I can tell you anecdotally that a lot of the residents that we worked with would come back and share with me the experience that it was a much more impactful conversation, or, oh, I told this family about it, and 3 months later at their next visit, they were enrolled. But I think it would be very interesting to study specifically, in a research capacity, some of the outward ripple of these changes and of this education. And I think Dr. Barr had something to say about that too.
Yeah, so it's interesting getting to see all the residents in the entire residency program come through DBP, and then also have the same residents, that smaller group that are in the core program. And so while this is not evidence-based research, I could just say from working with those residents who were in the core program versus the ones who were not, I definitely noticed in clinic with different patients in our DBP program that several of the residents who were in the core program and had already, worked with all of these community organizations were more knowledgeable and would bring up partnerships in the treatment regimen. So they might have thought kind of just that outside the box, or we would have a bigger discussion for treatment plans about how to connect that patient with more resources than we might have with some of the other residents who were not involved in the program. So they challenged me to kind of also think about other ways to help these children, because I think they were, so in the middle of that special selective. It was ongoing throughout the year. Although they did those first 2 weeks, they still had that partnership. So I think in their clinics with patients, it was certainly front and center to their mind.
Perfect. And I see we have another question here from Roland Gilbert. Have other cities expressed interest in your program? The answer is we haven't spread the word yet to other cities specifically. I think for me personally, I really wanted to get the 2 years under our belt. I think the first year went so well. We were all a little bit, hopefully I won't say shocked. We should have been prepared for that because we worked with such great organizations, but we were a little bit thinking, was that just an anomaly? Was that just a great year? But I can honestly say, after having done the second year through COVID, which was a very different and challenging experience, that the second year went really exceptionally well as well. So it is a concept that through educational means, meaning through some educational conferences on our end, that we've really started thinking about how to get the word out about. So we haven't formally been asked yet, but we're happy to have that conversation with anyone who's interested. I see Margaret Owen submitted a question here. Hello. Any ideas about spreading this information you generated through CORE to the broader community of pediatricians? Definitely. So we, as I mentioned, I really was pretty territorial about keeping it this way for 2 years so that we had some idea how truly it was going. But at this point, I think it's been so helpful to those who have taken this elective and to some other faculty that have sort of dropped by for certain presentations that we recognize at this point it would be better to expand. So we don't know 100% what that will look like, but we know that it's desired, and we're hopefully designing a system that will allow a broader reach for both these organization leaders and their presentations and the information from them. I also see, what about educating pediatric PAs about these resources? And I agree. So I hope I mentioned it. I might have been slightly flustered, but we'd love to do this with PEDS residence programs, but I don't think the concept by any means is only, applicable to them. I think it's applicable even outside of medicine, but I think to any learners, this would be a really valuable experience to have, specifically, obviously the ones in Dallas, because that's the group of organizations that we currently work with, but really a concept like CORE could be created wherever you end up training or practicing. And I see a lot of congrats. Thank you very much. I don't see any other questions. Dr. Barr and myself's information should be on the presentation. So if anyone comes up with something afterwards or would care to discuss that, we would be happy to reach out and have a conversation about that. I think that's all we have for today. I know that someone had a final slide. There we go. And I know that the presentation, the more premeditated recorded one, will be available online if anyone missed it or wants to look back at that. And again, Dr. Barr and myself are more than happy to have conversations. So please reach out. Thank you for including us. We're really looking forward to the other presentations in this series. Thank you, everyone.